etc., write notes, and the documentation time that it takes to do all this, and now spend another hour or so. Over time, we've gotten used to, I think we've gotten used to documenting way into the night, taking our documentation home, etc. But is that the way it should be? Well, thankfully, we've come to the point where we want to document medicine, or is it documenting instead of medicine? So that's kind of where we are at this point. When artificial intelligence has come in, it helps us analyze all this information that's coming in, as I mentioned. The access to the information, it also enhances the communication, it checks on the quality, and it even helps us to interpret some of the data that's coming in. And at that time, we get to sit down and analyze it. Now, when it was just the electronic medical record, as you see there, we had to do all this stuff. It wasn't, we were the ones pulling the data, writing it, and so forth. So, when I was first went to medical school and first started my residency, we were still on paper, on most of it. And believe it or not, that was so much faster. Now granted, our notes were a little different. I will admit that, patient find was one of my notes. But the level of detail that is required now is onerous. And so you find that for every 1 hour that you spend with a patient, you're spending about 2 hours of documenting. That's what came out in the Annals of Internal Medicine several years ago. And people have been advancing, as I mentioned, more and more how much time they're spending at home afterwards. So, with each era, we went, in order to advance medicine, we went from, using our memory and saying, okay, we know everything. We're going to use our information and help patients. Then we went over to evidence-based medicine, which was more data. And then finally, in the early 2000s and on, we went to electronic medical records, which became even more onerous. So as I mentioned, the goal now is to move things in a way that data can be analyzed so that it can allow us to spend more time with patients, which is where we should be. So what is AI going to do for us from a standpoint? It's going to summarize charts. It's going to look at labs, look at the data, reconcile medications, make sure there's no contraindications, etc. And at the end of the day, we look at this, it gives us that information so we can then interpret it appropriately and return the physician to the patient. So, data analyzed, and we're sitting and thinking instead of what you saw before, where we have all this other work. So there are 4 pillars that I would like to look at when it comes to medical information coming in and how we spend our time. There's the electronic medical record, or the EHR. We then allow that to be analyzed and organized. It's then presented to the physician, and with that information coming in, we then can spend time explaining it to the patient and spending time doing that whole sit and talk situation in the room instead of rushing in and rushing out. Now, what is important about this whole movement of artificial intelligence coming into any aspects of our life, but particularly in medicine, is the theory of, or the concept of, human in the loop or human on the loop. And what does that mean? So we call the loop when it comes to technology, etc., that when we move from one aspect to the other, so you have the information coming in, it's analyzed, and then there's an output. But we want a human always in that type of loop, because at some point you don't want it to be where we call it autonomous. We have our war fighters now want autonomy, electronic autonomy. Even Trump was fighting Anthropic in February. I don't know if you guys remember that. So that was a situation where they're wanting to allow robots to find the enemy, figure out a way to attack the enemy, and then proceed without any sort of human in the loop. That's, in my opinion, crazy talk. That's ultimately going to give us nothing but trouble. So we want a human in the loop at every aspect. So the AI will then analyze all the data that you see here, blood pressures, heart rate, lactic acid, etc., and then deliver our sort of early warning signs to say, okay, this is something to be concerned about. And that's when the physician comes in and says, and looks at that, looks at the patient, examines the patient, sees if the data fits the patient and if he needs to do something, and then we move forward with doing it. What we don't want is all that same analytics to go on. There's an alert, etc., and then the AI or the data says to do something without a person, i.e. a physician, saying, hey, let me evaluate the patient, let me see. There's certain nuances that you'll never see, but where the AI will never see, whereas a physician will always be able to understand. So I said all this now, but I'm sure people are wondering, well, can you trust this thing? Can you trust the computer to analyze your patient, to help to move you forward, even if at the end of the day, just to give you better time? Well, those studies have been done too. The New England Journal of Medicine just published last year how just implementing AI Scribe will, with the documentation, can give back an average of 30 minutes of time per patient. And that's significant, right? Because now you have time to do so many more things. And it showed a decreased level of burnout, which is a real thing in our profession. Now, talking about analytics, well, looking at all the things that it can do, does it analyze things better than we do? Well, I mentioned earlier, the whole concept really is that now we're at a situation where the computer can take on information from millions of individuals and then analyze just to see small nuances, small changes that can then be impacting on our single patient. So, there's a meta-analysis with over 6 million individuals that came up with a scoring mechanism for sepsis, which was allowed us to come up to about 93% accuracy rate. That's tremendously significant. Continuing on with the trust thought process is, okay, well, what is the computer doing with? So we call that in data explainability. Can you explain what you're doing through the process? That actually is a very big key process. You don't want this black box scenario where I give you information, I don't know what you do with it, but you give me an answer. That's the wrong thing, because at the end of the day, just like when I'm in surgery and I go and before surgery, I explain to my patient what I'm actually going to do to them, or the family member what I'm going to do to their loved one. That's the same concept that you want to be able to have with computers. You want to be able to explain, okay, it's going to take these numbers compared to this and then give us this result. If you come up with a system where you have a black box situation, I would strongly suggest back away from it, because you always want to be able to understand. You as an individual, as a physician, want to understand, but you also want to be able to at least give some sort of inkling to your families what's happening in this scenario. So that's where you want to stay. Now, the other aspect of this is we always talk about error rates, because that's always concerned. How bad is it? Or hallucinations. So at this point, with what we have in many of these programs, so forth, we're down to like a 1 to 3% error rate when it comes to scribes and when it comes to implementing things into the EHR. Well, you have to have a concept of what it was before. Well, I'll tell you, when we write things down or type things down from before, it was anywhere, best scenario 7%, and some places up to 20% errors in the documentation. So actually, we've moved way, like the relative reduction in error rate was tremendous in comparison to what we had before. So we're definitely going in the right direction. And then hallucinations down to low rates now 1.4. What we're saying with hallucinations is basically sometimes the computer will just literally come up with something and inject it into your medical record. And it could be something small. That's why you have to kind of review it, etc., make sure that it's agreeing with what the process is in your plans, But that rate is hugely low. I mean, it used to be up at 7, 8, 10% before. So here you can start to see that there's some level of trust that you can start to have with your patient. The other thing that everybody talks about, which is important in our situation, is bias. how does bias creep in? Now, we know that humans are the ones that are programming computers, so therefore the bias that humans have, i.e. the bias that we have in our medical system itself, is going to creep in. So we have to now build, I guess the best term would be adjuncts, so that we can identify the biases and then highlight them. So, every time we put together health without, so we'll be able to attribute that. There's one recent study that showed that they were able to identify biases that were in and reduce those biases so that you moved the patient population that was biased against, i.e. African Americans in this particular study, that we were able to reduce that by 19%, the 20% range. So that was a significant thing, because now all these individuals, over 200 million people were evaluated on this population base. You can see the significance in that number change. So at the end of the day, can we have a partnership with AI? Of course, this is going to come. We have to come, but we have to know how to handle this, how to handle these changes. Allow the organization of the data, the insights, reducing the risk and saving time. We do that part, while the AI interpret, decide, and we figure out how to care for our patients. So wrapping up, will AI ever replace us? No, because we need to do the part that I just mentioned, but also we can connect with grieving families. We directly talk to our patients about their fears and so forth. We also understand the cultural nuances. So you never have to worry that AI is going to replace it. It's just that we're going to be able to shift the way we interpret and the way we take care of our patients. It's EHR, AI, and then trust. As I mentioned before, there's been a significant increase, as I mentioned in the beginning, in adoption, which is great. Maybe in 2022, the study showed only about 20 to 30% of physicians were even starting to use. Now it's moved up to 81%. Many people are now understanding that the adoption of AI can now benefit their practices, and even 3 out of 4 physicians say that AI benefits their patients. So these are kind of the things that we want you to look at doing. As I mentioned, obviously read everything. Many of you have mentioned that too, but the bottom line is you don't want to blindly just allow AI to write your notes without you reviewing, etc. Make sure that it's explainable. The decisions that are being made are that you can deliver that information, not just for yourself, but to your patients. Any type of discrepancies that are flagged, please take a look at it and review and analyze those. What the blind spots are. So where is potential bias? Evaluate that and make sure we highlight that. And then always, as I mentioned, stay in the loop. We got to have our finger on the trigger, not blindly allow the machine to do the things it should do. So never outsource clinical judgment. AI should just augment physician intelligence. That's all I've got.